There was a man named Richard, 73 years old. He still drove himself to appointments, still mowed his own lawn on Saturday mornings, still played cards every Thursday night with the same friends he had known since the 70s. His daughter described him as sharp, alert, present, the kind of man who remembered everyone's birthday without writing it down. Somewhere in the 2 years before his fall, things began to shift. Slowly, the way seasons change, not in a single moment, but in a gradual accumulation of small differences that you don't notice until one day everything is different. He started feeling dizzy when he stood up too fast. He blamed it on standing up too fast. He started forgetting where he put his keys. He blamed it on being busy. He started feeling tired in a way that sleep didn't fix. That deep, pulling fatigue that sits behind your eyes and makes the afternoon feel like it's moving underwater. He blamed it on age. His daughter blamed it on age. His doctor ran some blood work, adjusted a few numbers, and didn't look at the pill organizer sitting on the kitchen counter. Then one Tuesday morning, Richard got up at 3 a.m., and the floor came up to meet him before he understood what was happening. 2 broken ribs, 6 weeks of recovery. At the end of those 6 weeks, his daughter quietly took his car keys and did not give them back. Richard lost his independence not to a stroke or a diagnosis anyone saw coming. He lost it to 3 medications that nobody had reviewed in 4 years. Medications that, combined in the body of a 73-year-old man, were doing something no single prescription had intended. Before we go any further, I need you to understand something. After 70, your body processes medications in a fundamentally different way. Your kidneys filter roughly 40% more slowly. Your liver metabolizes at a reduced pace. The barriers in your brain that once protected you from sedative effects become thinner and more permeable. A medication your body once cleared in 8 hours may now be circulating for 24 or 36. And when you are taking multiple medications, which most Americans over 65 are, those compounds interact inside a body that is no longer equipped to manage them the way it once was. This is not about being anti-medicine. Some of these medications save lives, and stopping them without medical guidance could be dangerous. This conversation is about something more specific, whether certain medications that were appropriate for you at a different age, in a different body, are still serving you now, or whether they have quietly become part of the problem. If you find this kind of information valuable, subscribe to this channel right now. We talk about this every week, because the truth is, most physicians are extraordinarily good at diagnosing and treating disease. What they are not always given the time to do, especially in a 12-minute appointment, is step back and look at everything a patient is taking and ask, does all of this still make sense together, in this body, at this age? That gap between what medicine intends and what actually happens inside an aging body is what I want to walk you through today. We are going to look at 7 categories of medications, not because they are always wrong, but because in my years of working with older adults, these are the ones I have seen cause the most silent, preventable damage, the kind that gets attributed to aging when aging was never really the cause. The first one surprises almost everyone I mention it to, because it doesn't feel like a real medication. You can buy it at any drugstore. It sits next to the vitamins. It has a name you recognize, Benadryl, or Nyquil, or Unisom, or any of the dozens of over-the-counter sleep aids and allergy medications that contain diphenhydramine as their active ingredient. For decades, diphenhydramine was considered harmless, mild even, something you took when you couldn't sleep, when your allergies flared up, when you needed to get through a flight. And for a younger body, that characterization is roughly accurate. The drug works, causes some drowsiness, and clears your system within a manageable window. But here is what happens in the body of someone over 70. Diphenhydramine belongs to a class of compounds called anticholinergics, substances that block a neurotransmitter called acetylcholine. Acetylcholine is essential for memory, for attention, for the moment-to-moment functioning of your brain. When you block it repeatedly, over weeks and months and years, you are not just inducing sleepiness. You are interfering with one of the fundamental chemical systems that keeps your thinking clear. Researchers at the University of Washington followed nearly 3,000 older adults over 7 years and found that consistent use of anticholinergic medications, including common sleep aids, was associated with a significantly increased risk of dementia. The effect was measurable, documented, and directly tied to cumulative exposure over time. Imagine a communication system inside your brain, thousands of signals traveling between neurons, carrying information, maintaining clarity, keeping your memory intact. Now imagine a substance that, every night you take it, puts a layer of static over those signals. One night, the static clears. A week of nights, it clears more slowly. Months of nights, and the system starts to function permanently at a lower capacity. The brain fog you attribute to getting older may have been accumulating in a pill you consider completely harmless. The American Geriatric Society's Beers criteria, the gold standard for medication safety in older adults, explicitly lists diphenhydramine as a drug to avoid in patients over 65, not to use cautiously, to avoid. And yet it remains one of the most widely used over-the-counter medications in that exact population. If you are using any sleep aid that contains diphenhydramine, even occasionally, this is worth a direct conversation with your physician. There are safer alternatives for sleep: melatonin at low doses, cognitive behavioral therapy for insomnia, medications with a cleaner safety profile in older adults. The goal is sleep. The method matters. The second medication on this list is one that many people have been taking for years, sometimes decades, without anyone suggesting they revisit the decision. Benzodiazepines, Xanax, Valium, Ativan, Klonopin. These medications were prescribed, often appropriately, often compassionately, for anxiety, for panic, for the kind of persistent nervous tension that makes daily life feel unmanageable. And they work. In the short term, they work very well. The problem is the short term became the long term, and nobody scheduled a conversation about what that means after 70. In an older body, benzodiazepines accumulate. They stay in the system longer. Their sedative effects are amplified by the same physiological changes we discussed: the slower kidney filtration, the reduced liver metabolism, the more permeable brain. The result is a compounding of effects that nobody intended when the prescription was first written. Slowed reflexes, impaired balance, a subtle dimming of cognitive sharpness that feels, from the inside, indistinguishable from simply getting older. But the most documented risk is falls. Research published in JAMA and analyzed by the CDC has found that benzodiazepine use in older adults significantly increases fall risk. And falling after 70 is not a minor event. Hip fractures are one of the leading causes of loss of independence in older Americans. That trajectory, a medication taken nightly for anxiety, leading to a fall, a fracture, a hospitalization, and a care facility, is not rare. It is one of the most common silent catastrophes in geriatric medicine. Before we continue, I know some of you are recognizing a medication you or someone you love has been taking for a long time. I am not telling you to stop. I am not saying your doctor made a mistake. What I am saying is that the body you have now is not the body that prescription was written for. That distinction deserves a conversation. Not a confrontation, a conversation. The third medication surprises people because it sounds almost benign. Muscle relaxers, cyclobenzaprine, methocarbamol, carisoprodol. They are frequently prescribed for back pain, one of the most common complaints in adults over 60. The prescription makes sense on paper. Your back hurts. A muscle relaxer reduces the spasm. You feel better. What the prescription does not always account for is what a muscle relaxer does to an older nervous system. These drugs work by suppressing activity in the central nervous system. In a younger body, that suppression is manageable and temporary. In an older body, it is amplified. The sedation is heavier. The motor coordination is more significantly impaired. The risk of falling spikes in a way that is disproportionate to what the drug's label suggests. And here is the particular cruelty of this dynamic. The person takes the medication because their back hurts, becomes sedated and unsteady, and then falls, which frequently causes exactly the kind of injury that creates new, lasting pain far worse than the original complaint. The Beers criteria flags muscle relaxers as potentially inappropriate for older adults for precisely this reason. The risk-benefit calculation simply changes after a certain age, and the people most likely to be prescribed these medications are often the ones whose bodies are least equipped to tolerate them safely. Now, before I continue with the next 4 medications on this list, I need to stop for just a moment, because what I am describing here is not just a list of individual drugs. It is a system, and the system is the real problem. Each of these medications, reviewed in isolation, may seem manageable, but most older Americans are not taking one of these. They are taking 3 or 5. or 7. And the interactions between them, the way sedation compounds sedation, the way blood pressure effects amplify balance problems, the way cognitive effects stack, that is the territory that a 12-minute appointment was never designed to navigate. If you have ever felt that the content in this channel describes something your medical appointments never quite reached, there is a reason for that. The link in the description and the pinned comment will take you to a complete program built specifically for adults navigating health decisions after 65. Over 20 modules, practical tools, and a framework for understanding your own medications and asking the right questions. Scan the QR code on your screen right now if you are watching on television, or find the link below. This is the conversation that should have happened years ago. Start it now. The 4th medication is the one that generates the most resistance when I bring it up, because people have been told, firmly, repeatedly, that it is completely safe. Proton pump inhibitors, omeprazole, lansoprazole, pantoprazole, Prelosec, Nexium, Prevacid. These medications are among the most widely prescribed drugs in America, and for many people with severe acid reflux or a history of stomach ulcers, they are genuinely necessary. I want to be clear about that, but here is what almost nobody tells patients who have been taking them continuously for 5, 8, 10 years. Long-term use of proton pump inhibitors is associated with significant depletion of magnesium, vitamin B12, and calcium. In older adults, magnesium deficiency produces muscle weakness, fatigue, and cardiac irregularities. B12 deficiency causes neurological symptoms, tingling, balance problems, cognitive changes that are almost universally attributed to aging. And calcium depletion, over time, contributes to bone density loss and fracture risk. Think about what that means. A medication prescribed to protect the stomach lining is quietly depleting the nutrients that protect your muscles, your nerves, your bones, and your heart. Not because the medication is inherently wrong, but because the body was never designed to suppress stomach acid indefinitely, and the downstream consequences accumulate in ways that take years to become visible. The 5th medication involves diabetes management, specifically older sulfonylureas like glipizide and glyburide. These drugs stimulate insulin production. In a younger patient with consistent eating habits, the dose is calibrated and manageable. In an older adult whose appetite has decreased, whose meal times are irregular, or whose kidneys are filtering more slowly, the same dose can push blood sugar dangerously low. Hypoglycemia in an older adult does not always look the way it is supposed to. Instead of trembling and sweating, it can produce confusion, sudden weakness, dizziness, symptoms that look like a neurological event, or simply like a bad day. A 78-year-old woman I worked with had been experiencing mid-afternoon confusion for nearly a year. Her family feared early dementia. The real cause was identified almost by accident. Her blood sugar was critically low. Her diabetes medication, unchanged for 6 years, was no longer appropriate for her current kidney function. A dose adjustment ended the episodes entirely. The system was not broken. The monitoring had simply not kept pace with a body that had changed. The 6th medication requires care in any conversation like this one because pain is real. Opioid pain medications carry elevated risks in older adults in specific, predictable ways. Sedation is deeper and longer lasting. Cognitive effects are more pronounced. And the interaction between opioids and other sedating medications, which many older adults are already taking, creates a compounding effect on balance and alertness that dramatically elevates fall risk. This does not mean an older adult in genuine pain should be denied effective relief. It means the risk-benefit conversation needs to happen explicitly, regularly, and with full awareness of everything else that person is taking. The 7th medication is perhaps the most paradoxical on this list, because it is prescribed specifically to protect the heart. Certain blood pressure medications can cause orthostatic hypotension. When you stand up, your blood pressure drops before your body compensates, and for a brief moment, your brain receives less blood than it needs. In a younger person, that compensation happens invisibly. In an older adult on blood pressure medication, that moment can be long enough to cause dizziness or a fall. The medication taken every morning to prevent a future cardiac event may be contributing right now to the falls that are statistically far more likely to end an older adult's independence. This is not a reason to stop blood pressure medications. It is a reason to have a physician thinking about all of this together. And together is the word that matters most. What I have described today lives inside a larger problem called polypharmacy. Multiple medications, each prescribed with good reason, but collectively creating a pharmacological environment no single prescription intended. The average American over 65 takes more than 5 prescription medications. The interactions between them are genuinely difficult to manage, even for experienced physicians. If you have stayed with me through this entire conversation, you are exactly who deserves a complete picture. The link in the description and the pinned comment below takes you to a program covering more than 20 areas of health decision-making, specifically for adults over 65, including a complete medication review guide and questions to bring to your next appointment. If you are watching on television, the QR code is on your screen right now. Scan it. Your independence is worth protecting with the same seriousness your doctor brings to every prescription they write. Act now, while this is in front of you. After 70, the question is no longer, does this medication work? The real question becomes, what is it costing your body now? That is not a question designed to create fear. It is a question designed to create partnership between you and your physician, between what was prescribed and what is still appropriate, between the body you had at 55 and the one you are living in today. Before your next appointment, write down 4 questions. Is each of my current medications still necessary at my age? Has the dose of each been reviewed in the past year? Are any of these interacting in ways that affect my balance, my cognition, or my energy? And what would happen if we reduce the ones that are not clearly essential? These are not confrontational questions. They are the questions of someone who understands that the relationship between your body and the substances you take changes as you age, and that staying ahead of those changes is one of the most powerful things you can do for your independence. If you found this valuable, like this video and subscribe. We cover exactly this kind of conversation every week. Tell us in the comments, do you or someone you love take any of the medications we discussed today? Share this with someone in your life who is managing multiple prescriptions without anyone stepping back to look at the full picture. Not because this video has all the answers, because it might start the right conversation at the right time. Subscribe so you do not miss what comes next. This channel is for people who believe that getting older does not mean becoming passive about the decisions that shape how you live. Fin de narrativa.